Hello, everybody. My name is Erica Moore-Holland, and I'm working for MSF in the Khayelitsha project as a rifampicin-resistant TB epidemiology activity manager. And today I'll be speaking about post-exposure management provided for children and adolescents who have been exposed to rifampicin-resistant TB in their households in Khayelitsha. And I will just be discussing our experiences having implemented these services within this high-burden TB community. Despite the large body of evidence suggesting that there is an age-related risk of progression to active TB after exposure, various different tuberculosis programs globally have focused on those less than 5 years of age in their approach to post-exposure management and the treatment of tuberculosis infection. Khayelitsha is a peri-urban township located on the outskirts of Cape Town in South Africa, and MSF has a greater than 20-year history of collaborating with the departments of health in this setting in providing innovative and differentiated models of care to address the large burdens of HIV and TB. And in 2007, MSF started specifically supporting the rifampicin-resistant TB program in Khayelitsha. Now, as I mentioned, Khayelitsha has high burdens of both HIV and TB. There's approximately 180 to 200 new cases of rifampicin-resistant TB detected annually, of which 70% are co-infected with HIV. Historically in Khayelitsha, our case detection rate of children and adolescents has been quite low and lower than what's expected in TB programs, with an average sitting at around 6% of rifampicin-resistant TB cases being less than 18 years of age. Programmatically, we might expect the case detection rate to be somewhere between 10 to 15%. And there's quite a bit of literature that exists talking about the challenges in engaging this population in care and detecting active tuberculosis disease, specifically in children. Recognizing the need to improve case detection in children and adolescents, and also to provide more robust post-exposure management for this population, MSF piloted a program to provide post-exposure management to children and adolescents 0 to 18 years of age who were household contacts of RIF-resistant TB cases. From 2017 onward. However, at the time, the standard of care was only focused on providing post-exposure management, including TPT, for those 0 to 5 years of age, or those with HIV infection if they were between the ages of 0 to 15. Because TPT was not the standard of care at this time, the focus of this program was on the routine and systematic assessment of children and adolescents to follow this population, do initial assessment to determine signs and symptoms of active TB disease, signs and symptoms of TB in order to rule out if there was active TB disease, and if there was no active TB disease, to provide routine follow-up over the course of 2 years for the population in whom there was no active TB disease. However, our team had multiple challenges with the implementation of this approach. We did publish on the challenges associated with this model of care in Public Health Action quite a few years back in 2019. And a lot of the challenges identified were having to do with the health system, community, and individual level. Now here you can see all of the different challenges broken down by the involved sector and some potential solutions. Some of our key barriers really in interacting with the population of interest was that the model of care was not patient-centered or family-centered. It required family members and their children to attend the healthcare facility, oftentimes standing in long queues in which there was no triaging system for oftentimes what were healthy child and adolescent household contacts. Really this posed as a barrier for many families in order to actually receive post-exposure management services, and therefore likely had an impact on the diagnosis of active tuberculosis disease, as well as providing follow-up support for these families that are likely to be impacted by TB or that are impacted by TB.